In this part of the presentation, I want to discuss the specific diagnoses that may fall into the category of rheumatic disease. And I think before we dig into some of the specific signs and symptoms characteristic of each of these diagnoses, we want to start to think about how common these diseases are in the context of the other musculoskeletal diseases that we may see. And the analogy that I think oftentimes comes up is when you hear hoofbeats, do you think horses or do you think zebras? So knowing that most places, the more common animal is going to be a horse. When you hear hoofbeats, you think horses, versus zebras are much less common. So as we think about these diagnoses and how many people we're going to see coming through our clinic with each one, we want to start to think about which are most common and which are most likely. So just within this small chart that I have at the bottom, so low back pain, quite common, neck pain, quite common, osteoarthritis, quite common. Probably the most prevalent rheumatic disease that is out there is going to be gout that we'll talk about, carpal tunnel syndrome, polymyalgia, and then rheumatoid arthritis is also quite common. And then we have this broad category, what we refer to as spondyloarthropathies. We'll discuss those in a little bit more detail, but there are many diagnoses that fall under that umbrella, some that we'll get into more than others. So kind of discuss that, but as you can see, this table at the top will give you a sense for how prevalent these diseases are, and just not to memorize the specific numbers, but to have a broad idea of how likely they are, which ones are more common than others. Okay, before we get into the nitty-gritty of each diagnosis, I wanted to go through some useful terms and definitions because these will come up as we discuss the different signs and symptoms. So monoarticular, oligoarticular, polyarticular. Articular refers to a joint, so these terms are just prefixes that help us discuss how many joints are affected as we think through these disorders. As I mentioned earlier, this big word spondyloarthritis or spondyloarthropathy, if we break it down, the word comes from different Greek word origins, and so spondylos is indicative of vertebrae in the spine, spondylo. If you think of spondylosis, spondylolisthesis, spondylitis, those are all terms referring to spinal pathology. Arthro is going to refer to a joint, so arthron, from the Greek arthron, refers to a joint. And then itis refers to inflammation, so inflammation of a spinal joint. So the spondyloarthritis or spondyloarthropathies are going to have that as part of their presentation. Dactylitis is a word that refers to swelling of an entire digit. So a visual that is often used is like a sausage finger. So the entire digit swells. It's not just at one joint. It's not just at one part. It's the entire digit. So that's one sign that we'll see in certain these diagnoses. Enthesitis, again, itis is going to be inflammation. And the enthesis organ is where a tendon or a ligament inserts into the bone. So it's the point of insertion. So these, if you think about it, are going to mimic a lot of times insertional tendinopathies. So we want to be careful as we try to differentially diagnose, because that's what it may present like as that enthesis organ is irritated. Sacroiliitis, inflammation of the sacrum, inflammation of the SI joint. So itis, again, is our suffix that clues us into that. So keep those in mind as we go through these different presentations. A little bit about the demographics in rheumatic disease. So as you see, individuals come in with certain sex, male or female. We want to know which is more prevalent. Age categories can help. These are not definitive things to diagnose, but these are things in your subjective or in your history that may get you to start thinking about these specific diagnoses. So gout, as our case study indicated, often has triggers. As we'll see in ankylosing spondylitis, there are certain maybe genetic risk factors, antigens that might be present we can test for. So those things might clue us in. There's possibility or maybe a higher possibility of these diagnoses. This is a table from an article discussing different diagnoses, different rheumatic diagnoses, and Again, not to have you memorize all of these, but this is kind of for your reference to compare and contrast, especially with some of these terms that we've talked about that are going to be either present or not present in the different diagnoses. So this is mostly for your reference. Not going to read through it, but we'll highlight some of the key points from this as we go through the different diagnoses. This is the, like I mentioned before, kind of the umbrella Venn diagram representation of some of these spondyloarthropathies. So there are some that are more axial or affect the spine preferentially. And as you can see, ankylosing spondylitis is one of those that we will discuss. There are also spondyloarthritis or spondyloarthropathies that affect more peripheral joints. And the two that we're going to highlight out of these Venn circles are going to be psoriatic arthritis here and reactive arthritis, also known as Reiter syndrome. But just so that you do have reference to this, there are overlap between these conditions, and there are types of spondyloarthropathies that we will not discuss, such as an IBS or IBD spondyloarthropathy. So just so you know, there are other less common diagnoses out there that fit under this umbrella term that we won't get into the nitty-gritty of. They do exist. Okay, so some of the highlights that I want to mention from each of these specific diagnoses to try to get you to start keying in on some things from patient history and presentation that might make you think one of these is more likely present than another. And again, just to reiterate, this presentation is not meant to make you a great person at diagnosing these rheumatic diseases. That's not really our scope. However, we do want to be aware of the possibility of each of these presentations, because if we suspect these diseases, the early referral and identification of them is crucial to get patients to seek medical treatment that is effective. And a lot of times that will be some sort of medication-based treatment, even if you're seeing them in physical therapy or other movement-related dysfunction or impairments. Likely some of the management of these diseases will be partially medication-based as we try to counteract the body's inflammatory response and autoimmune components of this disease. And it's particularly important as we try to prevent more serious sequelae or consequences of the diseases, such as joint destruction, as we see in rheumatoid arthritis or other conditions. We really want to catch it early so that management can be comprehensive, and we're trying to stave off those serious consequences. So just wanted to mention that. Don't want to make you a rheumatologist, but want to be able to screen, and we want to be able to identify what are some key things that might make us suspect. So within these different categories, I want to really clue in on the things that are most pronounced or most unique from each of them. But again, the charts, the tables are for your reference, so you can kind of come back and review and study. So with rheumatoid arthritis, we're going to think polyarticular is really one of the keys. I just got this typo. I'm going to have to fix that in the PowerPoint. And then the joints that are affected are commonly small joints, so fingers, hands, wrists. Psoriatic arthritis typically presents with psoriasis. So I know that's not on here, but we'll discuss that. And then these inflammatory components at nails or insertion of tendon, ligament to bone, swelling of whole digits. Gout with triggers commonly affects the great toe. Ankylosing spondylitis commonly in the spine, and we're going to see some imaging findings as well that are unique to ankylosing spondylitis. So certain lab tests can be useful in rheumatic diseases, particularly in rheumatoid arthritis. We're going to see these rheumatic factor, or also called rheumatoid factor, which are going to be these autoimmune antibodies. So rheumatic factor, rheumatoid factor is kind of the classic one, but also being identified are anti-citrulline antibodies, also called anti-citrulinated protein antibodies, so ACPAs. You'll see that abbreviation, anti-nuclear antibodies. Sometimes nodules will show up on imaging. With psoriatic arthritis, you're not going to have antibody tests that are positive, but again, you're going to have these key signs and symptoms. Gout is going to present with high uric acid levels. So gout, the joint dysfunction is due to these uric acid crystals or deposits in the joints. So that can be seen on imaging, not x-ray, however, but an ultrasound or MRI can show those deposits, and then some blood testing could be indicative of that. Blood testing in ankylosing spondylitis. So this genetic factor, high proportion of individuals with AS have an HLA antigen, human leukocyte antigen B27 that's present. And as the disease progresses, imaging findings are going to be a bamboo spine or progressive fusion of the spinal joints, usually starting low at the sacroiliac joints, lumbar spine, and kind of marching upward. So we're going to go through in sequence each of these diagnoses. And again, I tried to break it down into kind of a subjective, objective section to highlight some of the findings that you might expect in your physical therapy comprehensive evaluation. But I'm just going to talk through the highlighted portion, and then these slides are for your reference. So with rheumatoid arthritis, this is one of the ones that is more common. So you might be familiar with some of these characteristics. It is characterized by flare-ups and remissions. So flare-up of inflammation and then remission period where the signs and symptoms are usually less serious. So the joint pain, the stiffness, the achiness can spike, but then it can be managed, or you can have this remission period. Polyarticular, as we've said, affects small joints. And then we do have these systemic blood markers of antibodies, and then also some gross or broad markers of systemic inflammation. So elevated CRP and ESR are common in our RA diagnosis. This is a slide that kind of pictorially represents some of the pathophysiology of RA at the joint. And what we know is that these antibodies are going to attack components of the joint and lead to this synovitis or synovial inflammation and joint damage, progressive joint damage. And that's where we see some of the degenerative changes and joint deformities that characterize the later presentations of rheumatoid arthritis, because these joints are constantly under attack from these antibodies. The diagnostic criteria for RA, this is a 2010 diagnostic criteria from the American College of Rheumatology. And as we can see, the four main components with which patients are rated, and a higher score on this, you can see, is indicative of a likely diagnosis of RA. So joint involvement, as more joints are involved, likelihood goes up. Serology or blood testing, as these autoimmune antibodies are present, becomes more likely. Acute phase reactions refer to these global markers of a systemic inflammatory response. If those are present, it's more likely. And then the duration of symptoms. So longer duration of symptoms, as we spoke about earlier, the rheumatologic diseases are chronic and progressive. So the longer somebody's had these, the more likely rheumatoid arthritis is present. Okay, moving on to psoriatic arthritis. Key highlight in this is the first word. So psoriatic, psoriasis. Usually a skin lesion is present. And in fact, the majority of individuals with this diagnosis will develop psoriasis before arthritis. So they will have some sort of skin lesion, specifically psoriasis, before they have joint pain or inflammation. So that's key in your patient history to kind of query about that if it's not brought up by the patient. The key signs and symptoms, and these came up prior, but in a more than half of patients, they will have some sort of sign and symptom in these three categories. So an enthesitis, an inflammation at that, tendon bone insertion can mimic tendinitis. Like we mentioned, a dactylitis, there's swelling of entire digit. Nail dystrophy, this is kind of nail changes or degradation. And then with this specific type of arthritis, imaging will show actually new bone formation, so a buildup of bone, versus in rheumatoid arthritis, that's characterized by bone loss or demineralization. In psoriatic arthritis, there is this increase in bone, buildup in bone. Again, this is a pictorial representation of some of the signs and symptoms that you may expect within this presentation. Reiter syndrome. So a reactive arthritis, this is commonly described by a kind of saying that I think is funny but helps remember. And this particular patient with reactive arthritis can't see, can't pee, and can't climb a tree. And those three statements are matching or indicative of kind of the classic triad for this presentation, where somebody has inflammation and pain at three different sites. So the eyes, conjunctivitis, urethra, urethritis, and a joint arthritis. Commonly affects larger joints, different than the presentation as we saw in rheumatoid arthritis. So commonly at the knees and ankles, asymmetric, could be polyarticular. Enthesitis is a possibility and common at the Achilles insertion. So somebody could present with what could have been misdiagnosed as an Achilles tendinopathy, an insertional Achilles tendinopathy. So keep that in mind for reactive arthritis. Moving on to ankylosing spondylitis. As we highlighted earlier, spondy refers to the spine, itis, inflammation. Ankylosing is the progressive kind of marching upward and fusing throughout the spine. So it's more common in males over females. 15 to 40-year-old, as we see, this is usually a younger onset. So prior to the age of 40 is usually the onset that's described. And it could manifest in the beginning as a low back pain or stiffness in the morning. Often these individuals have a decrease and progressively more decreased range of motion as the spinal joints degrade and fuse. So a positive Schober's test, so a really sharp decrease in flexion range of motion. And I wanted to highlight here, so it's a bit of an older study, but the data on specificity and sensitivity, I think, is quite robust. So these this cluster of signs and symptoms can pretty highly sensitivity. If it's negative, rule out AS, and specificity, if it's positive, rule in AS. So I think these are important things to keep in mind because they do correspond with some of the things that we see that are common in ankylosing spondylitis. So if somebody has morning stiffness, if they have an improvement in their pain and symptoms as they move, as they exercise, onsets before the age of 40, if it's slow and gradual onset and the pain has been there for longer, pain, discomfort, stiffness has been there longer for 3 months, if 4 out of 5 of these are positive, high likelihood of ankylosing spondylitis. So that's kind of a nice cluster to use in your screening process for this disorder. For gout, we've talked about this quite a bit because of our case study. The classic onset is somebody wakes up with pain in the big toe, caused by excessive uric acid, usually as food triggers. Seafood, organ meats, red meat, I've heard, alcohol, fructose sweetened drinks can all be triggers. And it's really common in the MTP joint of the first digit, so the great toe, commonly affected in gout. More common in males than females, and males over the age of 40. SLE, or systemic lupus erythematosus. It's kind of a mouthful. This particular diagnosis has multiple systems affected, and so there are multiple manifestations as we talk about SLE. So as you think through your differential diagnosis between musculoskeletal and a rheumatic diagnosis, that was one of our main points, was that MSK is usually more localized to a specific area. Rheumatic disease is more widespread and global, multiple tissues, multiple systems affected, and SLE in particular really usually manifests with this multiple system complaint. So could be cardiopulmonary, tegumentary, MSK neuro, or neuromuscular, if you will, blood, renal, immune. So many systems and manifestations, signs and symptoms. Females more commonly affected than males, African American over Caucasian. So these are kind of some of the demographic features. Gross inflammation, fatigue is highly common. Skin lesions are common. Muscle pain, joint pain. Butterfly rash is also a characteristic finding in SLE. So Even though this isn't in a high percentage of people, you will often see this in textbooks going along with SLE. And that butterfly rash or that malar rash is on the face, so reddening in the shape of a butterfly. So it's very obvious visually if that's present. These are the diagnostic criteria for SLE. So this is an article, a 2016 article that lays out some of the different, so the American College of Rheumatology, their diagnostic criteria, and then this is a specific SLE organization or clinic that have come up with these criteria. So as you can see, they're broad criteria. We won't go through them in the nitty-gritty, but this is kind of for your reference. I think the takeaway on this one is how many systems are affected and the signs and symptoms in each. So multi-system effects for SLE. Treatments for this are going to be medications, as we saw, education, counseling, possibility of physical therapy, although there's a question mark there. I'm not quite sure about the efficacy of that. Possibly to treat impairments, but likely you're not treating disease process because it is an autoimmune disease, but we could be treating individuals with this as a comorbid disease, so it's nice to know the specific possibilities for systemic effects. Okay, polymyalgia rheumatica or PMR, the key to this, so poly, multiple, but myalgia is the real key. So versus many of these diagnoses that we discussed that affect joints, this PMR is going to affect muscles. So muscle pain or myalgia is going to be a key presenting factor for this. And so we're going to have to differentiate between a muscle pain that's a musculoskeletal origin, but we're not thinking joint in PMR. It's in the name, myalgia, muscle pain. Average age is a little bit older than some of the diagnoses we've seen. So average age is 70s, female over male. So older women, muscle pain, and it's going to be widespread. So widespread muscle pain, achy, stiff, be shoulders, thighs, bigger muscle groups, neck, low back. There could be some trouble with functional movements because of the muscle ache and muscle effects. Okay, so clinical takeaways from these different diagnoses and details from the different diagnoses. And I have this quote from John Wooden: "It's little details that are vital, little things make big things happen." And the reason I put that in there is just to remind us that the details that you gain within your subjective and objective examination are really crucial. So you are becoming really good information gathering physical therapists and entry-level physical therapists, and all of that information that you are feeling more confident to gain and reason through is really the crux of what's going to help you with your clinical decision making. So going through your thorough exam, taking a good patient history, onset, screening, doing your review of systems, how many systems are affected, what effects are there, is there joint pain present, muscle pain present, are there other things that might clue you in that are these systemic signs and symptoms that it might be a rheumatic disease. All those things are really important. The specific signs and symptoms, so this is a chart that we had you fill out in the very beginning, and these are the different rheumatic diseases that we highlighted throughout the presentation. These are my clinical takeaways. Whoops, we'll go back. These are my clinical takeaways that I think are really key and help me remember some of the specific presentations from these disorders, but I'd like you to fill that chart in and keep your own that you think are most valuable. So for me, in stereotyping these different diagnoses, I think rheumatoid arthritis, I really think polyarticular small joints. That's one of the key things that's going to clue me in or have me suspicious of that diagnosis. Psoriatic arthritis, skin lesions, and then do we have any dactylitis or whole digit swelling? That's going to be more indicative of the psoriatic arthritis, so psoriasis, skin lesions. Reactive arthritis, I remember by this catchy saying of the different systems affected, the different symptoms. Gout, that characteristic big toe pain or onset at that area. Ankylosing spondylitis, spinal dysfunction, starting in the low back, SI joint, progressively moving upward. SLE, just all of the systemic signs and symptoms that are present, fatigue being really common. If the malar rash is present, knowing or identifying that that's characteristic. The myalgia and polymyalgia rheumatica, I think, is going to be my key takeaway for that. So if you do suspect rheumatic disease, what is our course as a physical therapist? So here I've outlined a little bit of our progression from our exam where we're gathering all of our information. Then the outcome is to try to identify, has this patient been diagnosed with a rheumatic disease, and are we treating some of the impairments associated with it, or are we treating a musculoskeletal injury that's totally unrelated, but we want to keep in mind of that comorbid disease that they've been diagnosed with, just to be aware of it and aware of that medical management as we are with other comorbidities. In that case, if it's been diagnosed, a multidisciplinary management is likely already occurring. So they're likely seeing a rheumatologist, being managed by a primary care physician, having some sort of medication as part of the treatment for that. So communication with the other treatment providers is definitely important, and just acknowledging that that's going on. So it's not our job to diagnose, but we do want to be aware of some of the sequelae or some of the issues surrounding these diagnoses. And then this is perhaps more important, and this is perhaps the crux of a lot of what we talked about, is these undiagnosed rheumatic disease or screening for these diseases. So if you do suspect a rheumatic disease, referral could either be back to a primary care physician, or we could refer to a rheumatologist. So a rheumatologist is a medical doctor who is specialized in treatment and management of rheumatologic disease. And just quick mention of the training that potentially goes into that. So a couple of the rheumatologists that I refer to within my network, their education, so they went to medical school, they have a medical degree, they then pursued residency in internal medicine, and their training in rheumatology is via fellowships in rheumatology. So I thought that was kind of interesting. That just kind of gives you a sense for what their training course is or what their training path is. But oftentimes, in order to gain referral to a specialist just within our medical system, referral back to a primary care doctor is necessary. Sometimes you refer straight to a rheumatologist. It just kind of depends on the insurance, the patient scenario, what's going on. So, but oftentimes, again, like we said, to prevent more serious consequences of that disease, if it is undiagnosed or if we suspect it and we want to gain more testing for potential management of that underlying pathology, we do want to refer out, even if it's a treat and refer, even if we're treating concurrently impairments that we pick up in our PT exam, we do want to gain more information if we suspect that. So if we are tasked with treating an individual with rheumatic disease and we're trying to treat within this framework, kind of describes somebody who is having an acute inflammatory response or pain response. So they're in that period of the disease where they are experiencing symptoms. This is kind of a neat stage process that's been described in this particular article for management of these individuals. So not contrary or not completely different from how we might approach a musculoskeletal pathology. We first want to use our pain control techniques, modalities. We want to control the pain and inflammation. Secondly, we really want to restore motion, especially if it's a joint that's been affected. We want to maintain or restore as much healthy functional motion as we can. We want to restore strength around the joint to protect the joint and also to improve function, which is stage 4. So trying to treat the patient and get them back to these functional things they want to get back to. These are references for the presentation. Thank you for your attention, and I look forward to lab where we will be discussing particular case examples and how these concepts apply to case studies.